آه، هنتكلم عن النون سيمنتد توتال هيب. اول سؤال، هو تو يوز ذا unscemented توتال هيب. دي صوره من السويدش ريجستري بتقارن ما بين السرفايفل بتاع الانسيمنتد والسيمنتد توتال هيب ارثروبلاستي according to the age. زي ما احنا شايفين اللون اللي هو الريد ده الانسيمنتد، وباين ان هو في العيانين اللي اقل من 50 سنه السرفايفل بتاعه احسن. في العيانين اللي من 50 ل 60 سنه السرفايفل برضو بتاع الانسيمنتد توتال هيب احسن. في العيانين اللي من 60 ل 70 سنه برضو الانسيمنتد احسن. هاويفر في العيانين اللي اكتر من 70 سنه تقريبا السيمنتد احسن هو اللي افضل. ال 10 year survival بتاع الاولد اديشن اللي هم السكند جنريشن سيمنتلس implants up to 96%، وال 20 year survivorship حوالي من 85 ل 90%. وده في السكند جنريشن. في الثيرد جنريشن expected to be اكتر يعني. Also why to use the uncemented total hip. It's quicker, no cement, no wetting, no difference in the cementing techniques between individuals. Uh, for the history, the total hip, actually the total hip replacement started with uncemented implants, not cemented. The first one was done in London by Wills in 1938, as you see here, and the second was by Mackay and Farrar in 1956. After this, we came up with the ring type cementless total hip in the late 60s, which was an Austin Moore stem over a long threaded cone cup. However, it has a 66% failure at 5 to 12 years follow-up. Then we came up with the era of the cemented total hip by John Charlie, in which the cementless have declined. Then we came up again with the cementless show up at the early 70s because of the cement disease with the threaded cups. It has a promising results. However, it has about 30% revision rate and a high migration rate up to 56%. Also, there was in the first generation cementless cup, it depends only on the mechanical fit, no biological fit. For the second generation cementless acetabular cups, we have added the porous coating to provide the bone ingrowth. So we had the modified threaded cup, which had mechanical and biological fixation. It had a longer stability, but also it had difficult insertion. It's always vertical, so there's edge loading and high polyethylene wear. In the early 80s, we had the era of the hemispherical cups, which we are using today. So we have the second generation hemispherical cups like the porous coated anatomic from Haumedica, the Harris Galanti from Zimmer, and the anatomic medullary locking from Dupuy. So how to do the biological fixation when performing cementless total hip? It's critical to achieve a firm primary mechanical stability, followed by biological fixation. So we have to have at the start a primary mechanical stability, then the implant will have a biological fixation and the secondary stability. The osteointegration can be achieved by bone ingrowth or bone on growth. What are the basics of biological fixation? First, the pore size, shape, and the porosity, the implant stability or the micromotion, the interface distance, and the stress shielding. For the bore size, the better bore size to be included in the cementless implants is from 100 to 2000 micrometer. Why not below 100? Because below 100 no bone will be formed, and after 200 the fibrous tissue will start to be formed. So as this figure, it's better to be in the phase between 100 and 200 pore size. These different shapes of the pores, either titanium fiber mesh or cobalt chrome beads or titanium plasma spray. The micromotion, the uncemented implants require stability for bone growth. So for the bone to have an ingrowth from the implant to the bone, you have to have a primary stability. any slight micromotion between the implant may inhibit or delay the growth. If we have a micromotion of over 150 micron, only fibrous tissue will be formed. If we have a micromotion between 40 and 100, a combination of bone and fibrous tissue will be formed, and when you have a micromotion less than 20 micrometer, predominantly bone ingrowth will be formed.
تايمنج يا عنتر والنبي،
يا باشا
تايمنج بس عشان لسه كمان
خلاص تمام.
هيموتوه.
It's generally assumed that the initial stability better to be less than 100 micrometer. This is the end classification of bone ingrowth, fibrous stable or the fibrous unstable implants. Also in the stem. We will go quickly over this parameters. So how to achieve biological fixation for cementless cup? First, the cup material, the cup geometry, the surface coating, the cup fixation, and the modularity. For the cup material, either cobalt, chrome, titanium, or tantalum, the best is the tantalum. For the cup geometry, the Morsher described 5 types, either cylindrical, square, or cone, or ellipsoid, or hemispherical. The one we use right now is the hemispherical cups. The hemispherical cups either have a single geometry, like the Dupuy Pinnacle cup or the Continuum cup, dual geometry, which is abruptly enlarged, like the Dupuy Gription cup and Zimmer Biomed G7 acetabular cup, or hemi-ellipsoid gradual transition from the periphery to the dome, and it's no discontinuity between cup and bone, like Zimmer Triology, Duralock, or EcoFit Ebor cup. Surface coating, we have 2 types of surface coating, either porous coating for bone ingrowth or surface roughness for bone on growth. We can add anhydroxyapatite coating to allow biological fixation and long-term stabilization. The cup fixation, either press fit under reaming by 1 to 2 millimeter, and depending on the bone viscoelasticity, deformation, and recoil around the cup, the hope stresses will maintain the cup in position plus minus screws. It is stable more than line to line, and for this type, it's not recommended to use a dual geometry cup. For the line-to-line screw supplementation, if inadequate initial stability by hammering, you can use screws. You have to know the acetabular quadrants and less stable than the press fit. The disadvantage of screws is a pathway for a wear particle, the fretting corrosion, the motion between the head screw and the cup, and neurovascular injury. For the modularity, we have either a monoblock or modular. The monoblock, the shell and the liner are one piece, and the metal shell, for the modular, the metal shell and have a separate liner, so we have 2 pieces. This is the disadvantage and advantage of each one. We have then evolution of different modularities, either first generation modularity, second generation modularity, or our third generation modularity, like the cups we are using today. We have different polyester liners, either neutral, lipped, or offset, or constrained. We have other bearing surfaces, as Dr. Hatem said. Then, how to achieve biological for cementless stem, the same as the cup. For the material, titanium alloys are always used. For the classification, we have different classification for stem geometry. We will not discuss because of time. According to the stem length, we have 5 types: ultra short, short traditional, or long, or ultra long. And this is the different types and the different geometries of commonly used stems. Surface coating is the same as the cups, and the stem fixation, mostly for the stem, we are using the press fit principle. Failure of the cementless cup are due to either disruption locking mechanism, osteolysis, or loosening, and for the stems, either intraoperative fracture, stress shielding, or osteolysis or loosening. Thank you.
شكرا دكتور محمد على